Hi, everybody. Welcome to the Best of the Breast. We have 4 radiologists coming on tonight to talk to us all about everything you want to know about breast cancer screening. And they're a really awesome group of women, and I'm excited for you to meet them. I see some of them here. Let's see, Dr. Iffy is coming on now. Go live. Let's see. Accept.
Hello,
Hello.
Robin. How are
It's
you?
good. So good to see you.
Good to see you
See.
too.
Oh,
I love you. I love your shirt.
oh, thanks.
So
Marjan picked it out for me.
Oh my
I love
gosh, I'm
it.
so glad you got that, and I wish I had gotten one
Hey,
too. Why did I not buy one?
not too late.
Hi, Marjorie.
That's
Hi,
so
Amy. Oh
cute.
my goodness.
Hi,
This is
guys.
You stay
this is
outside.
so awesome being with you
Hi,
and you
hi,
girls.
Amy. Hi, Evie.
Hi. I
Hello,
can't believe
hello.
we're here. This is
Yeah,
awesome.
This is so great. So
so nice
I'm
to
gonna
see
give
you all.
I'm gonna let everyone say a brief introduction, your name, where you're from, where you practice, and yeah, and we'll get into it. Dr. Griffey, why don't you start first?
Okay, hi, I'm Dr. Effie McCurley. I am in Canada, all the way in Canada, in Calgary, Alberta. That's our province. And yeah, I practice with CDC. It's a private group, and just I do, lots of breast imaging primarily, but I do other things as well, like pain management, ultrasound, all that stuff. Yeah. So
Cool.
nice to be here with. This is I feel so amazing being here with all you ladies. This
Me
is
too.
awesome.
This is so wonderful. I'm so glad you could join. It's nice
Yeah,
to meet
me
you, Effie.
too. You too.
Amy, give us a little, tell us about
Hi,
yourself.
guys. So, I am a board certified radiologist, fellowship trained in breast imaging. I currently work full time at an academic women's hospital here in Pittsburgh. I'm also married and have 4 kids and just ran a half marathon this morning. So, switching hats. Happy to
The
be here
most
with you guys.
most productive woman I've ever met.
That's
Yeah,
amazing.
that's serious. I felt like I ran a marathon, but all it was taking care of 2 children.
I
Um,
hear you.
I'm Marjan Balori. I'm the mammo doc and also board certified breast radiologist. I'm in Denver. I've been in private practice here at the same group for about 11 years now.
Amazing. And my name is Dr. Robin Roth. I'm the Booby Docs, obviously, uh, as everything. I practice breast and abdominal radiology at it's academic hybrid community practice in South Jersey, and I've been practicing for almost 11 years now as an attending.
Wow.
Awesome.
Yeah,
I love your
time.
shirt too.
Thanks. Marjan,
Robin,
you have to
you and
get.
I
You have
are
to.
the same age,
Oh
which
yeah,
is fabulous. I mean, I'm sure we're all within like a couple years, but yeah,
practicing at that 10-year mark is like a big mark for in your career, right? It feels that
yeah,
way.
I
I've been
felt
Yeah.
that way.
practicing longer, much longer. I feel like
How long have you been practicing?
looks can be
I know.
deceiving. I've been in practice for over 20 years.
No
Oh,
Wow,
that's
look at
way.
awesome.
you.
Congratulations. That's so good.
But
Thank you. Yeah, it's crazy. Goes by so
Ify,
fast.
Ify, did you do like a combined program, or did you do 4 years undergrad and 4 years med school too?
Oh, so I did 3 years undergrad, 4 years med school, and 5 years residency. Yeah,
Oh,
Yeah.
so
Okay.
same.
yeah, it's the same. It's the same. Yeah.
All right. Well, I want to
That's so
open
good.
up the conversation. I know that like we've been wanting to get together because I feel like there's so much misinformation about mammography and safety and the radiation dose and everything like that. So we wanted to come together and answer all your questions about breast imaging, which you are welcome to join in the comments, but we can certainly kick it off with the things that we hear, that we get asked the most. Marjan,
Yeah.
what are some things that you get asked the most from your patients?
Well, obviously, number one is right now there's a lot of misinformation out there about radiation with
Mm-hmm.
mammograms. And a lot of people are asking, is a mammogram safe? The radiation and the compression. Um, And I'm happy to give my answer first, then we can all go around. So as we all know, the radiation dose from a mammogram is super low. It's a low dose X-ray. It's zero point 0.4 millisieverts. Whereas, and I had this in one of my videos recently, the radiation from a CT of your abdomen and pelvis is like 16 millisieverts. So we're talking
Mm-hmm.
30 times more. And the
Mm-hmm.
radiation from a lifetime of mammograms from age 40 to the end of your life is about one CT scan. So, no, you don't have to worry about the radiation.
I did not know that statistic, and I think that's a really important thing to mention. And the benefits of early detection far outweigh any potential risk from the small dose on radiation. Oh, good. I'm so sick.
Yeah, I knew that one was coming.
Yeah.
Thank you, Karen,
Yeah.
for asking.
Thank
So,
you,
what are your thoughts on
Marshawn.
QT imaging? Yeah, a great answer, by the way.
Oh,
How effective
oh,
is
Um,
I
it?
missed it. What?
It said, what are your
Someone's
thoughts on
asking
new
about QT.
QT
Oh, okay.
imaging and how effective is it? And thank you for asking. I feel like this is your territory.
Well, um, so I dove into QT imaging because I was getting so many questions about it. And there's really, unfortunately, no data about its effectiveness. They've only published one paper comparing its QT imaging to your gold standard 3D mammography. And they didn't even mention how effective QT imaging was at detecting breast cancer in that one paper. So, unfortunately, it's just a black box right now. It
Mm-hmm.
only has FDA clearance as something to use as an adjunct to mammography, in addition to, not on its own. So,
Mm-hmm.
so the FDA doesn't recommend that you do QT imaging instead of a mammogram, and there's no data to support it. So,
Yeah.
who knows?
And QT imaging, for those who are not familiar with it, is a type of ultrasound. And we've been using ultrasound for decades in radiology as a supplement to a mammogram. And the reason we don't use it to replace a mammogram is because it can detect microcalcifications that are associated with some of the earliest signs of breast cancer. DCIS, but also invasive cancer I've seen, as presenting as calcification. So, there's a lot of limitations about, ultrasound to replace mammogram. Certainly in QT imaging has been around for like about 10 years, which is nothing in the grand scheme of things. So you really need that long-term data and these long-term studies. Um,
yeah.
oh, good. So Karen said that I had my NYC doctor investigate and confer with several prominent doctors. The consensus was that it is not a screening tool. Thank you so much.
Yeah.
Yeah.
I
Yay.
I
Yay.
feel like I
Yay! Yes!
Oh, you made crafts. Like you like crafts.
no,
You can
I just
tell I have a
Yeah.
preschooler.
Oh, yeah.
that's so cute. Where are my little?
I
I have
like
them
that.
somewhere.
That's the best. Yeah.
Yeah, tell us what you're gonna say, Amy.
Oh, I was just gonna say, I was thinking about this the other day, and we all have so many thoughts on QT imaging. Number one, it's not supported, not regulated, not recommended, not proven, all of that stuff. And I just feel like it's not giving us anything that we don't already have. It has some quantitative data with ultrasound that we actually already have with elastography. We have that
Mm-hmm.
ability on our ultrasound units in practice. We were trained on that, and we don't actually use that because it's not helpful compared to everything that we already know and all the other characteristics that we use to assess lesions. And I was just thinking about it, and I was thinking that it provides a map of the breast QT imaging, but that map doesn't have any useful or information or any information that's proven to be useful as opposed to our conventional imaging that we have so much data on. That map with conventional imaging has all of the information that we know. And then just hopping right back onto the radiation thing, I know that's a huge topic. Some of the things that I learned when I was looking into it myself, they did have studies a long time ago from patients who were getting heavy doses of radiation based on imaging for tuberculosis and things like that a long time ago. And they did find that radiation-induced cancers didn't actually occur until like 10 to 20 years later. And then at SBI, they had a lot of stuff about the radiation and, you know, the 3 millisieverts for one mammogram is well under, like, I think it's 10 millisieverts for a year's worth of background radiation just living in the world. And actually, the physicists have made a statement saying that below that 10 millisieverts that we're getting normally in a year from background, um, they advise making any assumptions about detrimental effects from radiation under that 10 millisievert dose. So like anyone saying that it causes cancer is really based not on science as far as we
Yeah,
know.
I actually just want to mention that because someone said in the comments is that there's, one influencer, and we all know who she's talking about, that is
Mm-hmm.
basically pushes QT imaging and tries to scare us from getting mammograms. And this person, like we all, if a marketing tactic is to scare you away from getting something that all of your doctors are recommending and what science has been, supporting for decades, and then trying to sell you a new type of cancer screening that isn't approved by anyone, like your red flags should go up. And I think this is a very dangerous, slippery slope. And I posted about this recently that fear mongering and scaring people away from getting their cancer test and treatment is not a marketing plan. It's a public health crisis.
Yeah.
Like, people are getting their health information from social media. You want to trust someone because they have an MD, or they have some credentials that might sound appealing to you, but you have to know that this person bought a machine, is a full investor in this technology, like trying to sell it to you as though it's like a potion. No, this is
Yeah.
Yeah.
cancer screening. We can't be selling this type of thing.
Yeah. I think, to Robin, like one of the
Mm-hmm.
things I was thinking about is one of the reasons why people are somewhat drawn to something else other than the mammography is this idea of no
Mm-hmm.
compression, you
Mm-hmm.
know? And while there is compression in mammography, now there are new machines where you get control. You have the button and you can control how much compression you have. And another thing that I think was Margin that you touched on, or Amy, in your post, is that cancers mostly go to the armpit, right?
Mm-hmm.
That's one of the more common places that it goes to. And with things like QT imaging, that area is not seen as well. So it's
Right.
kind of like you're gypping yourself of the opportunity to find a cancer if it's early and it's there, right?
Yeah,
Yeah, I also,
QT.
uh, sorry, after that, I want to talk about also just radiologists, how much training we have to go into, and
Yeah.
that, we support imaging that's approved. Sorry.
Yeah.
I just,
Oh, I
yeah.
was just going to mention that QT imaging, you're basically submerging your breast in this water bath, and they themselves say it's limited for the upper outer quadrant and the axilla. So, we know that that upper outer quadrant is where breast cancer most commonly occurs.
Mm-hmm.
And then the axilla, the armpit, is where lymph nodes are first going to become enlarged.
Mm-hmm.
So yeah, like Ify said, you're totally missing out an opportunity there.
Yeah.
If you Mammography sees that area very well.
Mm-hmm. Yeah, and to be a breast radiologist, we've talked about this. You have to do 14 years of training, including med school. I'm blanking. 6 years of residency. Um, and we train in all types of medical imaging, not just mammography. We all read ultrasound, MRI, CT scan, things that make sense, but we have no breast radiologists supporting QT imaging. And the people that are reading it, it's advertised as being read by a radiologist. It doesn't say breast radiologist,
Mhm.
and it's not. We know, in fact, that it is read
Yeah.
by the person who owns the machine, which is conflict of interest
Such a
all
conflict.
over the
Yeah.
Yeah.
place. Yeah,
Yeah.
so dangerous.
Hmm.
And when
To have
and
a,
when it's abnormal, they recommend a
yeah.
mammogram.
Yeah. One of
Yes.
the things, yeah, to have a huge conference like the Society of Breast Imaging and to not have any QT there, that's a strong message that this is not something that is supported by breast radiologists.
Hmm.
Be
It was
careful.
it was a thermography, like, right before this. It was
Mhm.
thermography. We got smart. People started to hear that thermography is not used for breast cancer screening, but now they're like pushing on something new. And this is all, mostly from what I've seen, is funded by functional medicine, trying to scare people away from mammograms because of the small dose of radiation and
Mm-hmm.
selling them something new.
Yeah.
Yeah, it's like tech entrepreneurs trying to make
Yeah,
a buck off of women's vulnerability. So,
absolutely.
Yeah.
sad.
Don't get me started because it's in my backyard.
You
So
know?
Yeah,
That
you
would be
probably hear
hard.
about this more than
Oh,
the rest of us.
it's,
Fortunately, I don't get a lot of questions about it in real
oh,
life in Colorado, but
yeah.
certainly
There are
through social
billboards,
media.
Oh,
billboards. Like,
Oh,
really?
yeah,
that's
in
so
yeah.
Canada,
sad.
we're behind. We're usually behind, the states. Health Canada is usually behind the states, so it's going to be a long time before that even
Oh,
happens.
There's
You
only
haven't
eight
heard about it.
QT imaging centers in the country, in the world, actually. Seven of them are in the country. And, so it's small, but it's loud, right? Especially because there's, a few bad seeds that are kind of ruining it for everybody. Um, yeah, so it's a challenging thing. And I'm sure the QT, if QT imaging had potential and like it might, it's just not there. Like we're not even up to date on that yet. Like it hasn't even entered the radiology arena because we need long-term studies. We need things like that. So
yeah, unfortunately, they kind of put the business plan before the scientific proof. So
yeah,
they've been really,
Exactly.
really
I know.
trying to push it. And unfortunately, or fortunately, they're not doing well. They were listed on the NASDAQ less than a year ago and then delisted after less than a year because their stock was performing so poorly. And when you hear that about a company, it all comes down to the science. I mean, if the
Mm-hmm,
science were there, that wouldn't be an issue, but it's not.
mm-hmm.
So it's just smoke and mirrors. And I really hope more women aren't dissuaded from getting life-saving mammograms because of all
I
that.
just want to highlight this comment that Breast Recon MD PhD said, as a plastic surgeon who sees women with missed cancer because they skipped a mammogram, thank you. Need more intensive treatment. Thank you. And that's the point. Thank
Mm-hmm.
you.
Yeah.
It's early detection is a breast protection. It causes, we find it early. We could avoid more aggressive treatments and you just get better outcomes overall. So
Wonderful.
somebody else mentioned, and I think this is a great question. Can we agree that they need to change the age for mammograms? I'm 35. I found out at 34 I had breast cancer, and I have a
Mm,
friend who's 30
mm,
who found out she had breast cancer. You
Mm.
are preaching to the choir here.
Yeah, I mean, in clinical practice, I wish that it would be lowered for sure. Just because we see so many breast cancers and then those women age 30 to 40. And I think it is a real thing. And I don't know if you guys heard about the wisdom trial. I know this is not about but they're kind of looking at all of that information right now and seeing if there can be a difference in early versus late stage disease or survival if we're able to not necessarily screen patients at
Mm-hmm.
a younger age, but just finding those patients who are elevated risk and may benefit from screening prior to age 40. I think that's something
Yeah.
real to think about.
We could barely get 40 approved, right? There was even a group
Yeah.
saying 50. And I know
yeah.
Dr. Efi, it's 50 in
In
Canada, and that's a
Canada is
struggle.
50.
50.
Yeah.
Yeah, we're really fighting, and that's the federal law.
Crazy.
It's 50, and different
Wow.
provinces are doing different things, and it's there's such a difference even when it comes to supplemental screening. You're in the States, you're talking about MRI. My goodness, we're lucky if we get MR even for lobular cancers.
Mm,
Wow.
Okay, yeah, so exactly. Like I mean, most lobulars here don't get it.
mm,
So, I had a woman from another province, and because she came to our province, she had an ultrasound after her mammo dense breast, and we found a 4 millimeter cancer. And I
mm.
know that if she was back in her province, she wouldn't get that. So, yeah, there's definitely a case to be made for uniformity and definitely 40 or under tailoring.
Yeah, and I think that's a good point also that, especially the women who are under 40, but, well, number one, know your risk because average risk women need to start at 40 in America every year. But, certainly high risk screening for people that, younger if you have a high risk. But most people who are diagnosed don't have the risk factors.
Yeah.
But I think
Mhm.
that if you are young, below the screening age, I think you really need to be breast self-aware and get to know your breasts. Notice, if you find a change, speak up. I'm a big proponent of the monthly self-breast exam, even though it's technically not approved by the American Cancer Society, which
Same
is
here.
also
It's
Yeah.
crazy.
crazy. I know.
But
Yeah,
you have to advocate for yourself, especially if you're under the screening age, because
right.
right, We know that 80% of young people find their own breast
Yeah.
cancers.
Plus,
So
you're told, come if you find something different. How are you going to know if there's something different if you don't examine yourself, you know? Yeah.
absolutely. For some reason, I think that breast health and breast cancer screening is very paternalized. Like, start at 50 or 40 every 2 years because the anxiety you might get with a false positive. And and we don't do this for men. We don't do this for
Right.
prostate cancer
Mm-hmm.
screening. We give the facts, and we offer the recommendations to follow.
Right.
Whereas breast
Right.
cancer
I mean,
screening, it's
You
very
think we can
subjective.
handle it?
yes.
Yeah.
That
It's
is true.
exact. I mean, if a man wants a PSA, no one's going to say, no, you don't need a PSA. Oh, and
Right.
pat them on the head,
You
I
can
Absolutely.
mean,
handle the truth.
Yeah.
It is a weird thing,
It is.
and I'll never understand it, why there's pushback against it, or it's just not available.
well, and one of
Yeah,
my
there
big
was a
things is pregnancy associated breast cancer. And,
mhm.
the
Mm.
back when mammograms first started, there weren't as many or any women getting pregnant or breastfeeding in their 40s. But now there's
That is true.
overlap between women who need screening, especially high risk screening, and women who are pregnant or breastfeeding. And we can no longer just have some blanket paternalistic statement that, oh, pregnant women don't need mammograms or can't have mammograms, or
Yeah.
even so many, even
We should
my
do this.
OB after after I delivered, she said, oh, you can't have a mammogram for until you've stopped breastfeeding for 3 months. And I
Yeah.
actually had
I
to
know.
correct her and say, please
Yeah.
don't
We should
perpetuate this among our
we should
community.
we should bring this to a vote. Is it safe to get a mammogram while you are
Oh,
pregnant?
Yes.
I made my signs,
It's
guys.
okay, Amy.
I don't know what happened to them.
Ah,
Okay.
we can see it,
No.
Amy. We can see it.
Is it safe to get a mammogram while you're
Oh yeah,
breastfeeding?
Yes.
that's
And can you see
Yes.
things on a mammogram when you're breastfeeding? Yes.
Yes. Right. We usually tell people to like dump or feed the baby,
Yeah.
Yeah.
pump.
mhm.
No, you don't even need to
You
pump
don't
and
need,
dump. You
yeah,
just you just pump,
just
you feed the
pump or
baby,
feed. Yeah.
Yeah.
pump. Yeah.
And the
You might want to pump
radiation
and
does
dump
not
after
affect the
MRI.
milk.
Yeah.
Right, that's
Like
right.
the radiation does not affect the milk.
No.
Is
Yes.
you know?
And the amount to the baby in the
Oh, yeah.
fetus is minimal, minimal,
Yeah.
Yeah.
minimal.
Yeah.
You have the
My
placenta,
daughter
you
brought
have the
my
fluid.
signs.
There
Oh,
you
good.
go. I have a yes.
At least my
No.
girls are looking out for me. Are there any more
That's
interesting
awesome.
questions from our joiners?
Yeah, I can't see the question, so
Robin?
Robin, you let
Yeah,
us know.
I'm there's a lot of good stuff. Oh my God, you guys are asking some hard-hitting questions. I wanted to talk about breast density because I think that I know breast density now is in the chat and it's such an important topic. So who would like to give a rundown on breast density and why it's so important? If
You can do
Go for
that.
it.
yeah, you take
Yeah.
this.
Well, breast density is important. Like, when we as radiologists are looking at breasts, we're looking at A, B, C, D. And if you're A, that means you have more fat in your breasts. If you're D, you have less fat. If you have less fat, your breasts look whiter. And cancers on mammograms are white. And so white on white is a masking effect. It's much harder for us to see cancers. Not only that, if you have dense breasts, your risk of breast cancer is higher, right?
Hmm.
And that's mammogram results. Uh, just don't look at normal. Good. See you later. Know
Mm-hmm.
what that density is because you may qualify to get additional testing
Hmm.
like supplemental ultrasound and supplemental MRI where you guys are mostly in the States. In Canada, you can get it. And
Hmm.
there are some provinces that are working on it, but some places, some people choose to actually pay for it,
Hmm.
and you can, of course. But it's so important because when you add that ultrasound, we are able to pick up more cancers, and when you add MR, we can pick up even more cancers. Robin, and you guys may be able to speak to
Yeah.
contrast enhanced mammography as well, but
Mm-hmm.
it's so
Hmm.
important to know your density because it's I would say knowledge is power. Be your own advocate and don't just accept, yeah, it's normal, see you later. Ask for
Hmm.
more, no more.
Hmm.
Yes,
Okay.
Absolutely. Couldn't have said that better myself.
what she said.
Yes. Yeah. Somebody was asking, do any of our facilities offer abbreviated MRI? Mine does not, but because we offer contrast mammography, but I am interested, and Amy's does. So let's see. Does
We
Martha?
do.
Mm-hmm.
It's actually pretty cool. So we actually do a lot of supplemental breast MRI. It's kind of broken down into two categories based on breast density and then a woman's personal history. So we kind of have steered away from supplemental ultrasound and more to supplemental MR just based on the better sensitivity, specificity, cancer detection rate, MR versus ultrasound, and then lower false positive rate actually with MR versus ultrasound. So if a woman has extremely dense breast tissue,
Mhm.
automatically we recommend supplemental MR. If a woman has heterogeneously dense breast tissue and um, like one risk factor, we recommend supplemental MR. And then if they have a personal history of invasive ductal carcinoma and heterogeneous or extremely dense, they're getting a supplemental MR. Or if they have a personal history of invasive lobular cancer or LCIS and any breast tissue density, they're getting a supplemental MR. So we're doing a ton of them. And
Mm-hmm.
what we do is the very first kind of baseline MR a patient has, it's a full diagnostic protocol. And then every year after that, it's an abbreviated MRI,
Mm-hmm.
which we have shown in some institutional studies that we have done that the cancer detection rate, sensitivity, all those good parameters are equal to with abbreviated MR versus the full protocol. And abbreviated MR is quicker, cheaper, faster. It's easier for us to read just because there's less stuff to look at. Um, and it's a nice option. It's almost like down the road hopefully we'll be able to read those abbreviated MRs in more of like a
Mhm.
screening batch
Mm-hmm.
type of way.
Uh,
So
how long do they take, and how much does
Yeah.
it cost at your institution?
So at our institution, we're in Pennsylvania, so it should be covered
Mm-hmm.
through insurance with the laws that have been passed in Pennsylvania. We've had Senate Bill 595 and Act 1 of 2023. Those require insurance companies that are subject to state regulations, state laws to cover those supplemental screens. So
Wow.
if someone has a small private insurance that maybe isn't required to follow state laws, they might have an out of pocket cost. I'm not sure what that
Mm-hmm.
is, but we have pretty good laws and how long a full diagnostic MR is about 30 minutes and then an abbreviated MR is only about 7 minutes.
Wow,
Wow, that's
Mm.
amazing.
Wow.
that's
Good for
Yeah,
really
so it's
you.
quite
fast. Yeah.
a difference. That's helpful for patients who have history of claustrophobia and all that stuff. So
Yeah.
That's awesome. Yeah, and so we use a lot of contrast mammography at my institution, and I think that's a really great imaging modality that doesn't get enough credit. I think it would be really, it's not used in the screening population right now, but it should be. And I
hmm
would really like to see it in women that are dense and have, regular or average risk, or, maybe slightly above average risk of developing breast cancer, replacing the mammogram. It is a mammogram, but it's like an added bonus of you get IV contrast, and it's not gadolinium contrast; it's the iodine-based
Mhm.
contrast.
Mhm.
So you get all the
right.
benefits of finding the calcifications, but you get that physiologic component as well.
Hmm.
Yeah, we love CEM as well.
Yeah,
Yeah.
that's good
Yeah,
to hear.
just talking to people at SBI, it seems like things are moving more toward either of those two protocols for
Yeah.
your supplemental screen, either abbreviated MRI or contrast enhanced mammo.
Mm-hmm.
Um, where I practice, we're still doing a lot of ABUS,
Yeah.
screening
Mm-hmm.
ultrasound.
Yeah.
Um, it's fast, it's relatively inexpensive. Risk is absolutely no radiation, no contrast, so it's much easier to streamline, from a workflow perspective. But I do think just talking to people, they were like, "Oh, don't you have a lot of false positives?" So,
Yeah.
which we certainly do. So yeah,
Uh-huh.
I think those two are kind of the big
Mm-hmm.
big next
We
things.
we do handheld ultrasound as our other, we do MRI
Uh-huh.
and handheld ultrasound as our screening, which is, we're so
Mm.
fortunate to have amazing ultrasound
Mhm.
techs. I know
Yeah.
not a
Mm.
lot of places have that. So I feel like that does cut down on our false positives because they're only
Yeah.
showing us things that we know are real.
Yeah,
So,
we do ABUS as well, and handheld
mm,
and MRI as well, but more so the former two, ABUS, and I'm sure, I mean, everywhere there's a shortage of sonographers, right?
Yeah.
We're
Yes.
suffering.
mm,
So ABUS is kind of nice, and then where I am, we have the text pre-read it and
mm,
then send to us, and then we look at it, and it's
nice.
actually it's
Oh,
great.
So,
really?
I found 4 millimeter
Interesting.
cancers on there. It's
Mm,
wonderful.
with the
I have found some.
ABUS.
Yes, absolutely.
yeah,
Yeah, it's an amazing
right.
tool, and it's come a long way from when it first started.
Yes.
Yeah.
That's good. Somebody asked, what is recommended surveillance for someone who had breast cancer and successful mastectomy and reconstruction?
Oh, that,
So,
that's a great
yeah, that's a
question.
great question. You want to take this one, Amy?
So I'm assuming bilateral
I
mastectomy.
think SMX means single, but let's pretend it's double because you're going to do
Okay.
screening. Yeah.
Do
Yeah,
both.
so
Yeah, do
you
both.
know, I'm pretty sure Society of Breast Imaging, American College of Radiology, do not recommend screening in the setting of mastectomies. And we at our institution, we do not recommend screening in the setting of mastectomies. Now, that being said, we have found breast cancers in along the chest wall
Hmm.
in patients. So I think being vigilant about, reconstructed breast exams and following up with your doctor on a regular basis. And if there's any clinical, concern, definitely come in for imaging.
Yeah, and we start with an ultrasound after you've had a
Mhm.
mastectomy, usually. If there's any, question, we might get a mammogram or recommend an MRI, but certainly, biopsies, same way. But yeah, we don't do like mammographic screening of the reconstructed breast though after mastectomy and, deep flap reconstruction.
In your place, you don't. Do you guys image tram flaps, deep flaps? You don't.
No,
No.
No.
do you?
Do you
Do
guys?
you?
You do.
Yeah,
You
Oh,
yeah,
do?
wow.
See, I love
and we
that.
have and we have found.
Yeah.
I
Yeah.
mean,
How are you?
I've definitely found cancers in tram flaps.
How
There was
often are
that
they coming
one
in?
paper in like JACR from maybe 5, 10 years ago where they looked at their data, and I mean, they said that the recurrence rate in autologous tissue flap reconstructions approaches that of an average risk woman over
Yeah,
time. So their argument was you should, there's no reason not to screen them.
we do.
Um, but yeah,
There's breast
where I,
tissue, and some of the
yeah,
breast tissue is still there, right?
right.
I found it at the junction. I found it close to
Hmm.
the
Yep.
skin. It's there, and even in
Hmm.
mastectomy patients, if there's you have some mastectomy patients that have a lot of tissue left over,
Hmm.
Yeah,
and
we
you're kind of
do.
like,
Hmm.
is it really a mastectomy? Then we will. And again, I've seen quite a few cancers in patients that have had mastectomies. To what Robin said, people, patients are encouraged to be diligent about that self-breast exam, but sometimes you can't feel it,
Hmm.
you know?
That's
There's a
yeah.
lot of
That's so interesting because I feel
Surgical
like all the
things.
plastic surgeons I spoke to in the US do not recommend it like mammogram screening of a mastectomy, but it's interesting that you do in Canada.
Yeah, and it varies from place to place. Like where I started imaging and I worked for 20 years, we always image the chest wall. The
Mhm.
vasectomy side, we grab whatever. And man, I've seen some like ones where you're like, oh, that's probably a lymph node. It's not
Mhm.
a lymph node. It's a
hmm
Yeah.
cancer.
Mm.
And so when you've come across things like that, quite a bit, you're just like, no, how do you not do that?
Mhm.
And in some places where in busier practices, maybe they don't image the chest wall, but then if they do an ultrasound, they'll always check the chest wall. And man, that combo ultrasound and
Mhm.
mammo, awesome. Fine
You
things.
brought
Okay.
up an interesting point that, after mastectomy, there is residual tissue, varying amounts, right?
Yeah.
But I know we've all seen that on an MRI where it's like a patient's after mastectomy, but they still have like all this retroareolar tissue, and I think that's hard. That's a hard place. You tell the patient, you tell the doctor, like that maybe that there is enough tissue that you should probably screen. I don't think this is communicated.
Yeah.
Yeah, and I mean, yeah, there's definitely some tissue. I mean, I had a patient that had, she was a BRCA patient, and she had a mastectomy, and then she had a lump, and it
Mhm.
was adenosis, which means there's
Mhm.
tissue there,
Yeah.
Yeah.
right? So then the surgeon took her back and took away more tissue.
Hmm.
I think it's a good reminder because sometimes patients think I've had a mastectomy, I'm good.
Yeah.
Yeah.
There's still breast tissue there, you know, so
Absolutely.
Unfortunately, I had
And
a
yeah.
similar case of BRCA patient who had a prophylactic mastectomy. Somehow she got a MR, and she had a lot of ectopic tissue on
Mm.
both sides in her axillary tail.
mhm.
Mhm.
And I thought that that was significant. So I did make a point of relaying that to her referring provider because, that is
Yeah.
a risk.
Yeah.
And anyone,
Yeah.
and someone mentioned in the comments that if you've had a single mastectomy and you still, obviously
Yeah.
you have to do
Yes.
breast cancer screening for the if other breasts,
Right.
and knowing that also increases your risk, of developing cancer. Like if you plug it in the risk score, you might be eligible for MRI on the
Mhm.
other side now,
Mhm.
so.
Yeah.
Yeah, I think this is a good place where there's a lot of room for individualized screening plans,
Hmm.
where people really
Right.
need to just like if we see a cancer that's really far posterior and they're going for mastectomy, I mean that's someone you might say, hey, she's going for mastectomy, but think about screening MRIs.
Yeah.
And we
Mhm.
do have a few patients like that where,
Mhm.
we'll
Mhm.
try to make a point to screen them on a case by case basis. And just
Mhm.
to complete that thought, where I trained at UCSF, they did also do screening memos on the tissue reconstructions.
Mm,
Yeah.
interesting.
Just
Okay.
I wanted
we
to,
don't do them in my practice.
I wanted to ask the question, when should women get screened? And I know this is a, individualized approach, but as a woman listening, when should I start getting screening? Who's going to take this one? About who needs high risk? Who needs to start earlier?
Yeah, I mean, I think that we should be telling patients that they all need to have a conversation with their doctor by think we say what age 25 about potential
Hmm.
risks. And then I really like the idea that if they may be at elevated risk and are considering genetic testing, I was listening to something the other day to consider sitting down with a licensed genetic counselor, someone who's a professional in that area, because um, I think that they sit down with patients and really talk about, what tests are done and what will happen with those results before someone goes to get genetic testing. Because I've heard some patients just I'm kind of off on a tangent here, but run out to get genetic testing and then they have the results and there's a lot of anxiety about what to do with those results. So I think, I would recommend starting at age 40, at least at this point in time. Things are rapidly evolving, but definitely have a conversation with your doctor. Consider genetic testing if you're at high risk,
Yeah.
so that we can begin earlier if we need to.
Yeah, average risk women should start at mammograms at age 40. But those who have a high risk of developing breast cancer, if you go to use the Tyrer-Cuzick calculator and you find out that you have greater than a 20% lifetime risk of breast cancer, we actually start mammography as early as age 30 and MRI as early as age 25.
Mhm.
So, if and usually alternating every 6 months. So if a good rule of thumb is like 10 years before a first degree relative was diagnosed. So if your mom had breast cancer at 45, you
Mhm.
would start a mammogram and MRI at age 35, usually alternating every 6 months. If she was
Mhm.
35, you would start an MRI at 25
Yeah.
and then add on the mammogram beginning at age 30 and kind of alternating every 6 months. So,
It's interesting
Yeah,
that you bring
I
that
like.
up, Robin, because
mm-hmm,
in my practice, we actually go by the NCCN guidelines, which
mm-hmm,
don't specify that it has to be a first degree relative.
mm-hmm.
So they say 10 years before any
A relative?
relative's
Oh,
earliest,
that's good
yeah,
to
age
know.
at diagnosis.
Any relative?
So just any relative. Yeah,
Oh, wow.
that's per the NCCN. So if you
Oh,
look at
Okay.
just there, it's it's even more
that's very broad.
open to starting
Yeah.
earlier. Yes.
Yeah, so my
Yeah.
cousin had breast cancer, in 32, I was never told to start,
Mhm.
first
I mean,
to cousins.
obviously there's, yeah, it's,
Yeah.
it's, again, it's up to you. But yeah, NCCN technically would have you doing
Mhm.
25 and 30, but
I'm way
They're gonna be
past any of this.
changing that, Marjan, after watching this.
we're
They're gonna be
all
like,
of
"What?
screening age.
We're
Yeah.
changing this. We're changing this
Unfortunately.
rule. There's a mistake there." But I
Like on the breast.
just speaking to that high risk screening, or I think it's important, especially if you there's some racial groups, like for example, us as Black women or Ashkenazi Jewish women that have a higher risk. So I think that knowing your risk is important. So doing that, the Taracusic or the is it ibis
Mhm.
screening,
Hmm.
and even with that, I mean, as a Black person, I know that it's sometimes just not a cultural thing to do to talk about the C word
Hmm.
or what's in your family. So you're doing it
Hmm.
and it's generating a number. It may not necessarily be accurate, right?
Mhm.
So we just need to be diligent and know that these things, even though we have a lower incidence of breast cancer than Caucasian population, the mortality is higher. And it's because of factors such as these things, just to be more diligent and I just wish we could normalize that conversation. I did a post, we talked to our children about the birds and the bees pretty early on. We can
Hmm.
talk about our health and our
Yep.
breast health, and that should be a normal conversation, you
I
know?
Absolutely.
love that.
Yeah.
Oh,
Yeah.
also
And
to
you
keep in
mentioned,
mind that
sorry,
any,
no,
oh, sorry.
no, 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 you go,
to
you
keep,
go.
to keep in mind, to Dr. Ify's point, any family history of any malignancy needs to go into that calculator. So it's not
True.
just breast cancer that
Yeah.
increases your breast cancer risk. So, and to recalculate your Tyrer-Cuzick score anytime there's anything new and a new diagnosis of anything, your grandfather gets colon cancer, go and recalculate your risk, because it's
Yeah.
it's a it's a fluid variable. It's not just one and done.
I'm so glad you
Yes.
mentioned that actually, because I had previously calculated Beyonce's breast cancer risk based off her dad's being BRCA and
Hmm.
having
I
breast
saw that.
cancer as
Yeah.
like 30%. But now that her mom had breast
Yeah.
cancer too, she's over 50%.
Yeah.
So I think it's
Wow.
just a good conversation about, your breast cancer risk is evolving.
Yeah.
Yeah.
As more information comes to light, you might want to sit down and be like, well, what's my risk
Put it in
now? Because
there.
yeah,
Yeah.
so
Hopefully she's
it's
plugged
not a
into
one
a
and
high
done.
risk clinic.
Call me. I know. I always
Well, I bet she is. Those two girls, hey?
I'm sure she
Mm.
is.
after
Yeah.
her tour, we'll
Yeah.
contact her about her high risk
Yeah, we
screening
could
and
be
Maybe
her
breast.
maybe she could come
specialist.
on live with us and we can have a
Can
conversation.
you
Would that be
imagine?
so fun? Oh
It
my
would be
goodness.
so fun.
Yeah, that would be
She's a little
awesome.
busy right now.
Yeah.
Maybe after. What else do we want to talk about? Should we do a round robin of, the myths that are going around social media and, misconceptions? How about
Let's
that?
do it.
All right, I got one. So most people who are diagnosed with breast cancer have a family history of breast cancer. Oh, I was
Wait,
on.
Is it no or on?
does mine say no or on?
No, yours says yours says
We
yours
should have
actually is
written a
bad.
mirror image, right?
You need a radiology like right and left here.
This is my
Wait, did I make
dialysis
mine
Oh,
backwards?
oh wait.
Geographically
Yeah.
challenging.
Yeah.
Okay.
No,
All right. No.
no, this is a great question, Robin, because do you know how many times people are surprised when they say, "Oh, but I don't have it in my
Hmm.
family."
Yes.
I
And
don't.
I say at least 80%, sometimes up to 85% of people that have breast cancer do not have it in their family. So not having a history of breast cancer is not a safeguard. It doesn't, it doesn't prevent you from having breast cancer. But
I
that's
Right.
a high
I
number.
I have
Yeah.
something. What about I've had a lot of patients say, "But I breastfed my
Mhm.
kids. How could I have breast
Right.
cancer?" I didn't think that was a protective factor.
It
Is
is actually a
It
protective
is.
factor, but
It
it
is,
doesn't
yeah, it
matter because
is.
there's so many other things
yeah,
going on that cause breast cancer.
not a
Yeah.
big one.
Yeah.
So unfortunately, if you even if you breastfeed, it can still happen to you, I guess. Is
Yeah.
Yeah. If we knew the magical answer as to what could prevent, well, it'd be out there.
Hmm.
We don't know anything that can prevent it. We just know, just live your best life, do the best that you can, and
Yeah, I like to say that there are some lifestyle modifications that you can do to lower your risk of
A
breast
hundred
cancer, such
percent.
such as eating, a plant-forward diet, minimizing red meat, minimizing alcohol and smoking, and maintaining a healthy weight, exercising. But there's nothing that you can do to prevent breast
Yeah.
cancer. Like you could do
Yes.
all those things and still develop breast cancer,
Yeah.
which is
Yeah.
why screening is so important. Um,
Yeah.
yeah, I think that leads to my next question, is that all breast cancers present as a lump. True or false? Right. So the goal of breast cancer screening is actually to catch your breast cancer
Before.
before you feel
Before.
something palpable, right? Because once it's palpable, it's large. We're hoping to catch it under 2 centimeters, probably is much smaller than that.
Yes.
So that's why annual screening mammography is so important.
Yeah. Can I ask a question, Robin, to
Of
what you
course.
just said? Um, you just kind of mentioned about ultrasound. Why can't people just have an ultrasound instead of a mammogram? No
Mm.
radiation.
Well, ultrasounds can't detect microcalcifications,
Mhm.
and even some subtle architectural distortion. There are some things on a mammogram that we just can't see on an ultrasound, and that's why all the recommendations say that you have to get a mammogram is the gold standard for screening at this moment, right? Not to say that something better won't come down the pipeline,
Mm,
but this is what we're using to screen a large population of people to find the most cancers. In a perfect world, we'd all be getting breast MRIs, and
ultrasound.
but that's not feasible financially, and a lot of places you need these, like we you just we need sorry, I'm like I'm blanking, but just you need to be able to accommodate all these people that need breast cancer screening. And MRI is an expensive imaging tool. Mammography is cheap, it's effective,
Mm-hmm.
it's quick, it
Yeah.
meets the
Yeah.
criteria
Yeah.
for
Yeah.
screening.
And
Well, I
I
have
always like to,
another. Oh,
Yeah.
no, go on, Margin.
I was just gonna say I have another for fact or fiction.
Hmm.
Oh, I heard that if I get a mammogram and there is a breast cancer, it's gonna pop it and make the cells spread even wider.
Oh,
True
I've
or
never heard
false?
that one before, but no,
Yeah.
that is not
Oh,
true.
it's all over the place too. It's the same people that are
Really?
trying to scare you away from getting a
Yes.
mammogram and selling you something else.
Yeah.
Oh,
The
no.
compression is necessary because it really minimizes the overlapping tissue,
Mm-hmm.
um, so that you could actually see through it. Like we talked about breast tissue being white on a mammogram. So the compression is really important to spread the tissue out so we can actually see through
Yeah.
it.
Hmm.
And there's no physiologic basis that your breast cancer is going to be smushed.
Yeah.
Yeah,
Mhm.
Same with if we have to do a
and spread.
biopsy,
Right.
the risk of spread too is just so it's very minimal. And I always say, if there is an issue, a surgeon is going to need a biopsy
Hmm.
before they
Hmm.
see you. They need to see the results. So that's something that's necessary. And in my practice, I always use a coaxial method, meaning
Uh-huh.
there's a cannula that we go through, and the risk of spread is
Want to say
minimal.
hi?
Hmm.
Yeah.
Oh, I got a
Do we have a
child
visitor?
visitor.
Hello.
Always.
Let's
He
see.
loves to be on the
Oh,
Oh,
live.
hi. Oh,
Betty.
what a cutie
It's
pie.
almost
Cute.
bedtime, which means it's almost time to end the live.
Yeah.
But
Oh yeah, you guys are almost 8. I'm almost 6 o'clock here, so it's
Oh,
I
we're in the
know.
early.
same time zone,
You
Efi.
guys,
Yeah.
mountain. Yeah.
somebody said, what thoughts on AI technology to compare changes in screening images over time?
I
I
love
always
it.
say, I know.
So
Okay.
I was there for SBI. Amy and I saw the whole day together where they talked about AI on last Saturday, and the
Mhm.
experts all agreed in the next 2 to 3 years at most, we're all going to be using AI for mammo. AI is not going to replace radiologists, but radiologists who use AI will replace those who don't. So it's here. The cat's out of the bag. A lot of people are already using it, and the data is amazing. It's going to be a game changer, especially in rural areas where people don't have access to dedicated breast imagers like we are,
Mhm.
where you have general radiologists reading your mammograms. AI brings their level of accuracy up to that of a breast radiologist. So that's
Yeah.
huge. And then also places that have been using two readers to read their screening mammograms can get rid of that person. That frees up more radiologists for the workforce. It's huge.
Yeah, absolutely. And at the end of the day, you always need a doctor to synthesize the information and
Yes.
then perform the
Mhm.
biopsy if something was to be abnormal. So
Yeah.
I think we'll have
Yeah.
a job.
Yeah.
Oh yeah.
We're not using it we're not using it yet, I'll
Yeah.
say. But I think, I look forward to how it can help us improve our workflow and maybe do a better job at detecting risk. We saw those really cool AI things that could help with risk assessment when you're
Yeah.
reading, and things like that. So I think it'll definitely be helpful, but it's
Yeah.
not happening for us yet.
All right. Well, this was such a great live, and unfortunately, my little ones are calling, and I know we could talk about this, all this stuff all day, but this was such an informative and fun conversation, and I
Thank you
hope
so
people
much,
listening got
guys.
some information from it. So
Yeah, thanks everybody for joining. It
Thank
was so fun to
Yeah,
you
talk
thanks
for
to
all.
you.
It was
joining.
so
and
Fun
fun.
meeting everybody.
follow all these amazing ladies. They are
Follow all of
all a
us.
wealth of knowledge. Yep,
Yes,
Well,
we're
not
the
a lot,
best.
absolutely.
lot of
Best
information you all put
imagers.
out. Yeah.
All
Yeah.
right.
All right.
Bye
Have a
Bye.
bye.
wonderful
Have a
night,
good night.
guys.
Bye.
Bye
Take
bye.
care. Bye.